Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am Professor Adam Ahmed Adam. You are welcome to this parasitology lecture. It is about cryptosporidiosis. It is a zoonotic disease caused by the protozoan parasite Cryptosporidium parvum. Cryptosporidium is a coccidian, single-cell, obligate, intracellular protozoan within the phylum Epicomplexa. Transmission, sources of infection, humans and animals. Animals as cattle, especially cows. Other animals, cats, dogs, rodents, birds, fish, and reptiles. The infective stage is a oocyst, thick-walled and thin-walled. The infection takes place by the fecal-oral route through one or more of the 5S. It occurs by ingestion of the thick-walled oocysts. The oocysts are immediately infectious after their passage in stool. Also, autoinfection, internal infection, occurs by the thin-walled oocysts. Cryptosporidiosis is an enteric disease, but in rare occasion, the respiratory tract is infected by oocyst inhalation. The infectious dose, only one cyst is enough to cause the disease. Oocyst characteristics. The oocysts survive for 2 to 6 months in moist environment. They are resistant to chlorine and other disinfectants, but killed by ozone, desiccation, and ultraviolet light. Vehicles of mechanical transport of gastrointestinal infections, the 5S, fingers, flies, foods, fluids, and fomites. Cyst versus oocyst. Is there any difference between cyst and oocyst? Cyst is a protective and dormant stage of protozoa in the face of unfavorable conditions. It is like a spore in bacteria. It is a thick-walled cell. Oocyst is a developmental stage in the life cycle of protozoa, and it has nothing to do with unfavorable conditions. It is a thick-walled cell that contains a zygote. Life cycle. There are two types of life cycle that occur in the same host. Schizogony or merogony, the asexual life cycle, and sporogony, the sexual life cycle. The figure demonstrates the infected small intestine enterocyte. The swallowed oocyst resides inside the enterocyte just beneath the cell membrane, intracellular but extracytoplasmic. The life cycle. Follow the numbering. Oocysts are swallowed through one or more of the 5Fs. They infect the small intestine enterocytes. They exist releasing sporozoites. The sporozoites develop into trophozoites, and the trophozoites develop into schizomes. When the schizomes become mature, they rupture, releasing merozoites. There are two types of merozoites. One group becomes macrogametes and microgametes, initiating the sexual life cycle, and the other group becomes trophozoites, leading to asexual life cycle. The microgametes fertilize the macrogametes, leading to production of unsporulated oocysts of two types. When they mature, they form thick-walled oocysts that are excreted in stool, and also part of the unsporulated oocysts matures into thin-walled oocysts. They infect enterocytes. They hatch releasing sporozoites, leading to internal infection, which is autoinfection. Pathogenesis. Cryptosporidium can infect the whole digestive tract from mouth to anus, but the commonest site is the small intestine, especially the jejunum. The infection leads to mononuclear cellular infiltration of the lamina propria, decreased crypt size, and villus atrophy. The functional disruption leads to increased intestinal permeability, chloride secretion, and malabsorption, ending up into secreted diarrhea of large volume. The clinical manifestations. The incubation period ranges from 2 to 12 days. The average is 1 week. The most vulnerable people are the young children under 5 years of age, elderly, and the immunosuppressed. If the patient is immunocompetent, he or she presents with acute self-limiting diarrhea that spontaneously lasts in about 1 to 2 weeks. But if the patient is immunosuppressed, he or she presents with chronic, intractable, difficult to treat diarrhea that persists for months or years. The clinical manifestations. The diarrhea in cryptosporidiosis patients is copious of large volume, watery, and non-bloody. Notably, I'd like to draw your attention here that chronic, watery, and non-bloody diarrhea in an immunosuppressed patient is due to cryptosporidiosis. Asymptomatic carriers will also report it. Diagnosis, clinical assessment, then laboratory investigations. The specimen to be collected is stool, non-bloody and watery. In microscopic examination, the weight preparation, RBCs are absent, and also white blood cells are absent, but if found are scanty, few in number. Then smears of stool are made and stained by different stains. So you see here the microscopic appearance of oocyst when stool smear is stained with modified Nelson stain, safranin methylene blue stain, and immunofluorescent dye. Treatment. Supportive treatment. If the patient is dehydrated, to be hydrated. Improving of the immunity of the immunosuppressed patients. And also a drug to be given, nitazoxanide, that is used against Cryptosporidium. Prevention. Improvement of personal and environmental hygiene, provision of safe water for drinking and other domestic use, foods and fluids heating at a temperature at least 60 degrees Celsius, filtration of water, the filters retain the oocyst, washing vegetables in clean running water, and hand washing after risky activities, especially contact with animals. This is a figurative demonstration of preventive measures, hand washing, prohibition of defecation in open spaces, safe disposal of excreta, flies fighting, and safe water supply. By this, the lecture is over. I hope that it is understandable, and I wish you all the best.